I'm very grateful for the invitation, and I will give a brief overview of some of the intrauterine surgical interventions that I have been involved with over the decades in fetal medicine, and then we can have a chat with anybody asking any questions. So I will start off with Rizas disease. This is where the mother's blood group is Rizas negative and the baby is Rizas positive. And the antibodies in this case transfer themselves through the placenta from the mother, and they attach themselves onto the fetal red cells. The fetal liver and spleen recognize the antibody coded red cells as foreign bodies, and they destroy them. The babies become anemic, and when they're severely anemic, they can die. The first man to describe the possibilities of interventions was this man in New Zealand, Liley, who in the early 1960s suggested that when the red cells get destroyed, you have a release of bilirubin into the amniotic fluid, and through the assessment of by amniocentesis of the bilirubin content of the amniotic fluid, you could determine whether the baby was severely anemic or not. In the subsequent years, I had described how we can take a fetal blood sample by cordocentesis, where we can put a needle through the mother's abdomen into the umbilical cord, take a fetal blood sample, and assess the degree of fetal anemia. When the babies become very anemic, they enter this red zone, the hydrops zone. They go into heart failure, and the baby becomes hydropic. We can see in the middle slide, it has tense ascites, and on the right, you can see how the heart is pulsating very weakly, and there is a pericardial effusion. We can also, in these babies, assess the velocity of blood in the fetal brain, in the fetal middle cerebral artery with Doppler, because the babies that become anemic, they develop a hyperdynamic circulation. And from the assessment of the velocity of blood in the fetal brain, we can predict whether the babies are severely anemic or not. And this is how we manage the condition. In the early 1980s, we used to put a telescope inside the uterus. This is me being very young at that time. Inside the uterus, puncturing the umbilical cord under direct visualization, and then giving a blood transfusion. But in subsequent years, we were able to do this by ultrasound, and we use ultrasound to guide the needle into the umbilical cord, you can see on the right, or into the fetal heart, and then give a blood transfusion into the cord or into the fetal heart. And we repeat these blood transfusions every 1 to 3 weeks, starting from as early as 16 weeks in very severely anemic babies. And then when they get to about 34, 35 weeks, we deliver them. And this illustrates again how we do it. We go through a needle, through the mother's abdomen, we puncture the umbilical cord under ultrasound guidance, and then we inject blood into the fetal circulation. And now more than 90% of the babies are surviving, however badly affected they are. And in Cairo, in your university, there are people that have been trained. It's one of the leaders there that was my fellow a few years ago, and this treatment is being given in Egypt. Fetal shunts is where we put these drainage tubes through a cannula into the fetal thorax or into the fetal bladder. And we have to assess when we see pleural effusions, these collections of fluid around the lungs, what are the possible causes, and then we can put these drainage tubes so that one end of the tube is within the thorax, the other end is into the amniotic cavity, and this way we drain the pleural effusion, and many babies today are alive as a result of this intervention. Another intervention is in babies that have obstructive uropathy, usually boys with posterior urethral valves, where they get a big bladder, severe hydronephrosis, we get renal failure, and these babies die at some stage after birth. In some cases, we can bypass the obstruction by putting these drainage tubes inside the bladder and draining the fluid into the amniotic cavity. Now, laser, and that is what was shown in the surgeon's cut, endoscopic laser, which I started in 1992, and this is in babies that are monochorionic, and where there is twin-to-twin transfusion syndrome. In these pregnancies, we can identify by looking at them at 12 weeks with this very thin membrane if they are monochorionic, whereas if they are dichorionic, they have a thick membrane that separates the two. Monochorionic twin pregnancies have a much higher risk of miscarriage and perinatal death and fetal growth restriction and premature birth because there's hemorrhage from one baby through the connecting blood vessels in the placenta, because these babies are connected, and one baby is losing blood and becomes severely anemic and can die from that, and the other baby is receiving too much blood and can die from heart failure because of overtransfusion. And this is us in 1992 when we started doing these operations. By ultrasound, you can see that one baby is stuck in one part of the uterus because it has oligohydramnios, whereas the other baby, that is the recipient, is producing a lot of urine in response to the blood transfusion that it's receiving, and this baby develops polyhydramnios. And this illustrates how we can identify these pregnancies, and we can use endoscopy, put an endoscope inside the uterus. We identify the connecting blood vessels, and then we use laser to cut through these vessels. And it is illustrated on the right. Here is the two babies. You can see the telescope going down, identifying blood vessels on the surface of the placenta, and then you use laser to cut through these vessels so that the two circulations are separated. And many thousands of these procedures are now being carried out throughout the world. And we have good survival rates depending on the severity of the disease. If you have relatively severe but not extremely severe disease, we get survival rates that are nearly 90% of at least one of the babies in these babies, and in more than 70%, both of the babies survive. With most severe disease, the survival rate of at least one baby is about 80%, and both babies surviving is a bit more than 55%. There's another condition sometimes where you have identical twins, where the two umbilical cords are very close to each other, and one baby becomes the pump twin and pumps blood not only to the placenta and back to itself, but also across the placenta into the other baby. And the other baby eventually stops, the heartbeat stops, and it's receiving blood retrogradely from the umbilical cord of the surviving baby. And this baby continues to grow, but it has no heart and it has no brain, and we call it a cardiac anencephalic twin. And in these cases, this twin appears like a tumor which carries on growing and can put into heart failure the other baby. And what you can do, you can put a needle, identify the vessels in the pelvis of the anencephalic baby, and then use laser to cut these vessels. And you can see this whiteout that accompanies the obliteration of the blood vessels. We also have tumors like pulmonary sequestration, where you have a tumor in the lungs, in the chest, and we can identify the connection to this tumor directly from the aorta, and then we use a guided needle and we laser these connecting vessels so that the tumor shrinks away. Diaphragmatic hernia is when there's a hole in the diaphragm and the viscera, liver, spleen, sometimes the bowel goes inside the chest. the lungs are compressed, and because of the compression, they don't develop normally. And soon after the baby is born, when the lungs need to function, the babies die from asphyxia. So in these cases, this great surgeon, many years ago, Professor Michael Harrison in California, he started doing open surgery, bringing the babies out, correcting the defect, and then putting them back. In subsequent years, they used to bring the babies out and block the trachea. The reason for the blocking of the trachea is that the lungs produce fluid during the course of the pregnancy, which escapes from the trachea into the amniotic cavity. And if you block the trachea, then the lungs can be expanded because the fluid is retained within the lungs, and that stimulates lung growth. This is what was happening in the 1990s and early 2000s, but the survival rate was relatively poor. So together with Professor Deprest in Leuven in Belgium and Gratacos in Barcelona in Spain, we introduced an endoscopic method of treating this condition. Under local anesthesia, we put a telescope inside the uterus, we identify the mouth, we go over the top of the tongue, this is the roof of the mouth, we go down past the uvula, and then we identify the epiglottis, and we go behind the epiglottis, and then we find the arytenoids, and we go across from the oropharynx into the trachea, and you can see here the vocal cords. We go past the vocal cords into the trachea, that is the carina, and we deposit a balloon. We do this at around 26 weeks in pregnancy, and then we let the lungs grow, and then we go in again at around 34 weeks, and we remove the balloon through a similar type of procedure. We identify babies as being at very high risk of dying by looking at the size of the lungs, and on the basis of this, we can predict what is the likelihood of dying if we do nothing. And we have taken a series of babies where the chances of survival was less than 25%. We put in balloons, and then we improved the survival. We doubled the survival to about 50%. After that, we carried out a major randomized trial to prove that this is indeed beneficial. Open spina bifida is something that you can see with an open spine there. The nerves are exposed, and the babies become, they develop hydrocephalus, they become paralyzed. And you could diagnose this condition from the early 1970s. In the 80s, I described how we can look at the shape of the head and the cerebellum to predict whether the babies had spina bifida. And then in the 2010, we described how you can identify babies with spina bifida from the first trimester of pregnancy. Recently, in the United States, they did a trial where they do hysterotomy. You open up the uterus, and then you try to have direct surgical repair of the open spina bifida, with the rationale that if you repair the defect before birth, then the nerves that would otherwise be exposed to the amniotic fluid, which is toxic, could be damaged. And if you close the defect prenatally, as you can see in the video, then they proved that you can reduce the chances of paralysis and the development of hydrocephalus after birth. What we have done through one of my research fellows who has been working in Brazil, this is Denise Lapa. She developed a purely endoscopic way where you just put an endoscope inside the uterus, you inject carbon dioxide into the amniotic cavity, having removed the amniotic fluid, and then you can undertake this surgery directly by an endoscopic approach. So this is all I wanted to say, and to give you an overview of what is the current state of affairs in terms of fetal surgical interventions and how they evolved over the last few decades. So I would be happy now to answer any questions.
We have
students
from the Faculty of Medicine at Ain Shams University based in Cairo. We have a number of questions. First,
yes.
Would you please describe us your feelings when you gave life to your first baby?
Say it again, please. Say it again. I didn't.
Describe us your feeling when you gave life to the first baby.
Well, it's an extraordinary feeling, isn't it? You have babies that you are watching die in front of your eyes, and you feel very, very helpless. And then when you have tried something new and you are lucky enough, with the help of God, you have succeeded and the baby survived, it is the most wonderful feeling that you could possibly imagine. And this goes across all fields of medicine. You are all medical students, and one day you will all experience this incredible feeling, and we are all very lucky being doctors, and you have this incredible access to suffering people, and it's the biggest gift that we have had to be able to save some lives.
We noticed that the mothers where you are having the procedures upon are fully awake. Doesn't it form a more stress than the normal situation?
Yes, often surgical procedures are carried out under general anesthesia or heavy sedation or epidural anesthesia. In these cases, it is all of these procedures are entirely outpatient procedures, and the women are awake. I think it is quite important that they participate in the operation. They understand what is happening. They can see for themselves, and they can see if things go wrong or if we are successful. It requires a special relationship between the doctor and the patient to be able to make them feel relaxed so that you can carry out the procedure without any major anesthesia, only under local anesthesia. And I think in the movie, again, you can see how I establish a very close relationship with the patients during these operations.
Yeah. Thinking outside the box. You thought out of the box, and luckily it succeeded. From an ethical point of view, some people might argue that this may open the door for some doctors to use patients as lab rats. How could we reach the balance to allow medical advancements and prevent using people as lab rats?
I was again. I mentioned that in the episode where I say that the doctor sometimes is very excited. A researcher wants to try some new methods, and it is very important that we go through a rigorous process of discussion amongst our colleagues. We have ethical committees that review what we want to do. Certainly nowadays there are very, very strict regulations that prevent somebody that is a bit crazy from undertaking procedures that have not been tried before. So nowadays, if you think of something new, you have to go to the Innovative Procedures Committee, discuss it, the potential benefits, the potential risks, and then only after they give you permission do you undertake the procedure.
During the episode, you mentioned a very deep phrase, I feel I'm still human. What is the deep meaning to be human after those years?
Yes, quite often people think that when you are involved in fetal medicine, or indeed any medicine, and you have seen a lot of suffering and a lot of death nowadays, many doctors are exposed to daily massive numbers of death from coronavirus throughout the world. Do you become dehumanized at a certain point? Because you just say, okay, next, this one has died, and then we go to the next room and look at another person, and most probably that person will also die. So you stop having any feelings. And I have not become dehumanized over the years. Each time I see suffering, I suffer myself. If I do things and they don't work out, I feel extremely sad, and I feel sad for quite a while. And that is what I meant. I remain human. I have not, you don't become accustomed to the suffering and the death of your patient, and it just becomes part of your routine, and you just do it without any feelings.
Is fetal surgery a subspecialty of the obstetric?
Yes. Yes, you train in, that's what I had to do. I trained in obstetrics and gynecology, and then I went into fetal medicine. When I was a junior doctor, there was no such thing as fetal medicine. So we were at the beginning of this new field. Yeah, so you train in obstetrics and gynecology, and then you go into fetal medicine. Yeah.
Do you recommend a special textbook to expand knowledge in this field?
I expect that, and I'm sure that most textbooks of obstetrics and gynecology now refer to many components of fetal medicine and fetal surgery. Within your university, within Cairo University, I visited a couple of years ago, and I gave lectures, and they gave me an award when I was there. I know that there are good fetal medicine and surgery doctors, and they are within the Department of Obstetrics and Gynecology.
What are the risks and complications of the fetal surgery, and how common is it nowadays?
Well, we have a uterus, and we have to breach that barrier that separates the intrauterine from the extrauterine life. There is a risk that as you are entering with your instruments inside the uterus, you may hit the placenta. And of course, the placenta is a very vascular organ, and then you have a massive hemorrhage. You cannot see anything very much anymore, and then the baby can easily die, and the mother is being placed at risk of a big hemorrhage. The other thing that happens is that there is a great risk that you can cause infections because you're introducing foreign bodies inside the uterus. So these are the two major complications, really. The risk of hemorrhage and the risk of infection.
What do you think is still missing in the fetal medicine field, and where can we advance?
Sorry, I didn't quite get that. Tell me again, please.
What's still missing in the medical field? We mean, where can we advance?
How can we advance?
Yeah.
We have massive advances now in genetics, in molecular biology, and those will have massive impact in the way that medicine advances and medicine is administered. Molecular biology will classify different disorders more specifically. There will be no such thing as hypertension. There will be hypertension of a certain genetic type, and therefore the characterization of disease and the tailoring of the treatment will be modified dramatically by the genetic makeup of any individual. At the same time, we have major advances in information technology, in imaging technologies, in artificial intelligence, and our whole life, not just medicine, will be altered by these major advances. You know, when I was a medical student, we used to have most of the surgery by open surgery. So if you had a peptic ulcer, if you had a gastric ulcer, the duodenal ulcer, you have to have a major surgery where you had vagotomy, You have to cut the branches of the vagus nerves. Nowadays, you can almost be treated by buying some drugs off the counter or from a petrol station. You don't need to have this major surgery. In cases where you have to have cholecystectomy, again, a major operation. Now it is all done as an operation where you just have an endoscopy, and then the next day the patient is gone home. So we have seen a major transfer from open surgery to endoscopic surgery, and now we are seeing major advances in interventional radiology, where radiologists are carrying out extraordinary operations. You don't need to open people up anymore. You do through imaging, direct needles, instruments, catheters into different parts of the body. So the same trend will continue, and it will be exponentially improve. Imaging, artificial intelligence, molecular biology. Yeah.
How would you advise someone who is seeking that specialty?
I think that you need to qualify. You need to, during your student years, begin to develop your own interest from what you have seen. You will find people that are mainly physician-like in their way of thinking. They like to think. And you have others that are interventionists, surgically minded. The advantage of fetal medicine and obstetrics is that it gives you a wide spectrum of conditions into which you can subspecialize. Somebody may be interested in oncology. They can do gynecological oncology. They may be interested in outpatient gynecology. Again, a lot of endoscopic procedures. Or they may want to go into infertility and make a lot of money, or fetal medicine and not make too much money.
Is it easy for a pediatric surgeon to specialize in fetal surgery? Or
yes, in the United States, a lot of the fetal surgery is carried out by pediatric surgeons. The pioneer of fetal surgery that I showed his photographs in my presentation, Michael Harrison, who is now in his 80s in California, was a pediatric surgeon. The major centers in the United States, like in Philadelphia, they are of pediatric surgeons. In Europe, it was obstetricians and fetal medicine people that have undertaken fetal surgery. And we had a different ideology. You could see the surgeon, the pediatric surgeon, opens up the uterus and brings the baby out to operate on them. We use minimally invasive endoscopic approaches to achieve the same thing.
We're very sorry to hear that you were recently diagnosed with one of the forms of leukemia. How did your illness affect your work? And how did you find the motivation to go work with the tiresome treatment?
I didn't get the second part. Yes, I was diagnosed in October, November 2019 with multiple myeloma. And at that time, I didn't know how it would go. I had chemotherapy in the beginning of last year, and then I had a marrow transplantation in July, and things have gone well. The problem was, of course, in the middle of it all, we had the COVID crisis. So somehow in the middle of the crisis, I had to keep away from the hospital. So from last March, I've been unable to go to work, and that I have missed a lot. But now I am feeling well, and I have gone into remission. I have had my vaccines, and I am very happy to tell you that on Monday, I will be going back to work.
We are really happy to hear that from you. Upon a special request from Shuru Tariq, one of the medical students who are aspiring to become like you, if you have one minute to send a message to medical students in Egypt, what would you say?
What I have What I have to tell medical students is that they're very lucky. You are lucky to have chosen a field of great service to humanity. I think of no other profession that can give you the satisfaction that you can get from medicine. I think that whoever wants to go into fetal medicine, there is a continuing great future. You're dealing with mostly healthy people. Pregnant women are mostly healthy, but then 1 in 100 or 2 in 100 will have to be given the bad news that there's something seriously wrong with their babies. And then you are faced with terrible dilemmas around life and death. A smaller proportion will have conditions which we can intervene and treat and cure in utero. It is a very exciting field and has certainly been very fulfilling for my life. So I wish them luck.
I'm really pleased to have this talk with you, Dr. Nicolaides. It's a great honor. Thank you.
I thank you.
Thank you.
And I wish you all well.